Okay, so I think we're ready to go ahead with a talk about the shoulder. It's an area as maybe you can, I've explained, I'm very passionate about. I truly feel that there is way too much MR of the shoulder done in this country. I think ultrasound should and will be, with the financial pressures on our healthcare system, the initial procedure of choice when the rotator cuff is of clinical suspicion for pathology. So we'll go over a brief history of, this long road in the United States to get to the point where we're starting to consider ultrasound as the initial procedure in the assessment of rotator cuff disease. Talk about some of the performance guidelines that have been established. Competency examinations for musculoskeletal ultrasound in general are being constructed as we speak, and I'll explain, tell you a little bit about that. Go into talk about normal anatomy, the ultrasound appearance of the various structures that are important to evaluate when you're looking at the rotator cuff, and the transducer position on the patient as you're looking at the various tendons of the rotator cuff. Obviously technique, which we've talked a little bit about, and we'll skip over actually some of, which duplicates what we talked about in terms of beam perpendicularity and those sorts of things that we just covered in the last talk. Pitfalls, same thing, we'll gloss over that again really closely. And we have some pathology that I can go over with you as well. Help you understand what full thickness and partial thickness tears look more like. So one of the earliest articles just in general regarding musculoskeletal ultrasound was written back in 1978, and I like seeing this because that was my first year in ultrasound. And it was written by Peter Cooperberg up in Vancouver, BC, in the evaluation of using ultrasound to evaluate rheumatoid arthritis of the knee. The earliest articles in the United States describing ultrasound appearances of the rotator cuff came in 1984 by Dr. Bill Middleton from Mallinckrodt. And Dr. Larry Mack up at University of Washington wrote this article in 1985 looking at the accuracies of ultrasound in diagnosing rotator cuff disease. The American Institute of Ultrasound and Medicine, which is a multidisciplinary organization dealing with all aspects of ultrasound, and so incorporates obstetricians, internists, orthopedic surgeons, musculoskeletal radiologists, multiple disciplines. Anyway, the disciplines that were interested in musculoskeletal came up with these minimum performance guidelines for the shoulder, which included looking at the biceps tendon, the subscapularis, supraspinatus, infraspinatus, and posterior labrum, with optional views to include the AC joint, the teres minor, looking for impingement with some dynamic maneuvers. You can see the coracoacromial ligament, but not part of the complete study. And the spinoglenoid notch, and to be honest with you, I'd move the spinoglenoid notch over here because I think it's a very important structure to look at with every complete shoulder study, to look for the possible presence of a spinoglenoid notch cyst, ganglion cyst, when you have a posterior labral tear. You can see that, and it can cause entrapment of the suprascapular nerve. And so it's a very, very critical finding to recognize when it's present. Competency examination that's being developed currently by the American Registry of Diagnostic Medical Sonographies. This is the organization that gives all of us as non-physician sonographers our competency, our piece of paper on the wall, and it's divided into various competencies from OB to abdominal to vascular, and being developed currently as musculoskeletal registry. There's also an emergency medicine registry that a lot of emergency room physicians get do their competency through the ARDMS, and I anticipate that because it's going to be the earliest competency exam, that a lot of physicians will take that test so that they have a demonstrated competency in musculoskeletal. That's expected to become available later this year. So the shoulder examination begins with the biceps tendon, and there's a couple of anatomic landmarks that are very, very useful when doing rotator cuff sonography. The biceps tendon when you get lost, Go find the biceps tendon, and then your mind can wrap around everything you're seeing. So the biceps tendon is done with the patient in a neutral position. You can rest their hand on their lap, and you're trying to place the transducer across the upper arm, across the intertubercular groove, where you have the lesser tuberosity on one side, the greater tuberosity on the other side, and the biceps tendon in between. So if you take a look at this CT scan so that you have the bony landmarks and the subscapularis tendon, this cross-sectional image corresponds with an MRI that will look this way. Notice that the biceps tendon on MR is dark, and you don't see those individual tendon fibers that you do see on ultrasound, because those tendon fibers brighten up, they reflect sound. So this demonstrates that spatial resolution improvement that you get with ultrasound imaging over MR. Long axis of the biceps tendon is simply achieved by turning the transducer 90 degrees to the previous angle and recognizing the linear distribution of hyperechoic tendon fibers along the deep part of the bony aspect of the intertubercular groove. Subscapularis tendon is medial and anterior to the, not anterior to the biceps tendon, but medial to the biceps tendon. So when you're looking at, what I like to do is come up to the top of the groove and have the patient, while I'm holding the transducer over the proximal groove, externally rotate, as you see here, and that will bring the fibers of the subscapularis tendon right out under the transducer. And you can see when your sound beam is perpendicular to the tendon fibers. Notice here a little bony erosion in the proximal footprint of the lesser tuberosity. After looking in long axis at the subscapularis, we're going to turn our transducer and look in short axis or across tendon fibers. Also with the patient in external rotation. One thing I'd also recommend is, I see this little gap between the elbow and this patient's lateral body wall. Important that you remind the patient when you're doing this to keep their elbow in against their side. Otherwise they'll just do this and it doesn't really externally rotate. External rotation, remind them to keep their elbow in and externally rotate from there, and it'll bring more of that subscapularis tendon out into view where you can see it well. But in short axis, you're going to see those tendon fibers on end, and the subscapularis is unique among the rotator cuff tendons in that it's comprised of tendon bundles, which you see here, and zones of anisotropy in between those tendon bundles, which can be mistaken as vertical tears, so you want to be careful not to misdiagnose that. Recognize that for what it is, just the interface and some anisotropy in between those tendon bundles in short axis of the subscap. The supraspinatus tendon comes out from under the acromion to insert on the greater tuberosity. And in short axis, again, notice this bristle brush appearance, seeing those tendons on end. It lies just posterior to the biceps tendon and is the other tendon besides the subscap that comprises the rotator interval. To look at the rotator interval, either have the patient in what's called modified CRAS, just bringing their hand up to their side with their fingers pointed down and their thumb forward, or I like to just rest their arm down by their side, and I like to try to bring their biceps tendon up so that it's over on top, so that you can see the subscapularis on one side and the supraspinatus on the other, and you can recognize the sling of fibers from the superior glenohumeral ligament come over the top. And that rotator interval is very important to look at because it comprises a large percentage of rotator cuff tears. The anterior distal portion of the supraspinatus, right up against the distal biceps, or right up against the biceps tendon. So how often asked, how much is supraspinatus, where does the supraspinatus end and the infraspinatus begin? There are a couple of ways to identify that. Up over the humeral head, where you have a more dome shape appearance to the bony surface, and you'll recognize the articular cartilage, you'll see this oblique line where the supraspinatus fibers override the infraspinatus fibers that are more posterior. That's up over the humeral head. Down along the greater tuberosity, there are two flattened portions of the tuberosity, the anterior one of which houses the fibers of the supraspinatus tendon. Posterior fibers, or the posterior flattened area of the greater tuberosity houses the fibers of the infraspinatus tendon. And the interdigitation of those fibers take place over the protuberance of bone in between. So the supraspinatus tendon, as we mentioned earlier, comes from the glenoid labrum out from under the acromion to attach along that anterior flattened portion of the greater tuberosity. So in long axis on MRI, this is the appearance of it. And on ultrasound, notice again how you see those individual tendon fibers coming over. The overlying subdeltoid bursa, deltoid muscle, subcutaneous fat, and of course the bony humerus, distal, the footprint of the greater tuberosity and the humeral head. In order to see as far proximally as possible, the patient needs to be placed in crass position to stress as much of that supraspinatus tendon out from under the acromion as possible. If it's too painful for them to go back, then again that modified crass position, which I described earlier, where they just bring their hand up to their side. Most everybody can do that, even if they're in some degree of discomfort. So it's supraspinatus, again, long axis with MR. And with ultrasound, this blue box corresponds to the area that we're seeing on the sonogram. Overlying subdeltoid bursa. Now here's one where you don't see that little tiny sliver of fluid because you're just seeing those two opposing peribursal fat planes right up against each other. The infraspinatus comes from the back to attach to the greater tuberosity, and inferior to that is teres minor. So in short axis, looking at the infraspinatus tendon, you'll see fibers on end. In long axis, you'll see the fibers in their length, and you'll see this characteristic bird's beak appearance, as you will also see with the supraspinatus tendon. The footprint, if you're looking in long axis at the infraspinatus tendon versus a supraspinatus tendon, you'll notice that the angle of this flattened area of where the infraspinatus fibers attach is shallower. It's a steeper angle of that anterior one. So if you're looking in long axis, you're wondering which one's which, you can almost feel yourself going from that anterior flattened portion to the posterior flattened portion, and you'll feel your transducer often rub right over the protuberance of bone separating the two. Subdeltoid bursa again, you might see a little bit of fluid, you might not. Often I would encourage you to always look down the arm 2 or 3 centimeters. The subdeltoid bursa extends over the distal to the distal point of insertion of the rotator cuff down 2 or 3 centimeters, and that being the most dependent portion where fluid can go is oftentimes where you'll see it, as you notice here. So here you see distal insert, and you see a little teardrop of fluid in that distal part of the subdeltoid bursa. Posterior aspect of the shoulder, very important to look at. Posterior humeral head. This with a transducer placed just below the scapular spine in an axial body plane, where you'll then see the humeral head, articular cartilage, infraspinatus muscle, posterior glenoid labrum, and the important area to look at, the spinal glenoid notch, just medial to that. Frequently you'll see the small artery beating here, suprascapular artery beating here, and immediately lateral to that is where the nerve is. You always want to assess this for glenoid cyst with the patient in internal rotation, just bring their arm across their front side. In external rotation, there's a vein that becomes very prominent in external rotation, and if that's the only position you look at the patient in, you might mistake that for ganglion cyst. So if you see that in external rotation, bring their arm across an internal rotation and it'll just flatten right out. If it's a real finding, if it's a ganglion cyst, you won't. Gotcha. AC joint, you can look at very quickly with ultrasound. You're basically going to assess it for capsular bulge, ganglion cyst, and irregular bony contour that you'll see with osteoarthritis. Cortical ligament you can identify quite nicely. Some pathology real quick. Biceps tendon, short axis, fluid around. This is probably a normal amount. Not probably, it just flat out is. This can be a normal amount. When you get this much fluid around the biceps tendon, that's an abnormal amount. Probably reflecting biceps tenosynovitis or rotator cuff tear. Biceps tendon tear can come with minimal retraction. You see a defect here, torn end here, distally, proximal torn end here. Empty groove, where you have the sheath still intact, but the biceps tendon is torn and recoiled, empty groove and short axis, and then this recoiled tendon has so many interfaces doing this that it just results in kind of an area of shadowing down at the musculotendinous junction. Important to look at the bursal contour of the cuff in long axis. It should always be convex in a normal cuff. If there's areas of dipping, deltoid or bursal dipping into an area of volume loss, you'll recognize that. You can dynamically move the patient around to demonstrate that. Also want to look at the bony surface of the greater tuberosity. Most rotator cuff tears are insertional and will pull off a little bit of the cortical surface of bone. And you'll recognize that cortical irregularity along the tuberosity with insertional tears. Full thickness tear frequently is misunderstood. It has to communicate the joint space with the bursa, with the overlying subdeltoid bursa. So a rotator cuff tear that goes from here to here is not a full thickness tear. That's a bursal-sided partial thickness tear because you still have tendon fibers proximally preserving the integrity of that cuff, and you don't have communication of the joint space with the overlying bursa. Examples of partial thickness tears: a bursal-sided tear. Notice the bony irregularity where the tear occurs. Smooth bony surface here and intact tendons at the proximal footprint, constituting a partial thickness bursal-sided tear. An articular-sided tear is where fibers are torn and you have hypoechogenicity along the along the articular side of the tendon. So when an orthopedic surgeon puts their scope in the joint space and looking back up, they'll recognize this one. This one they won't see. Nor will they see this one, which is an intersubstance or interstitial tear, not communicating with either side of the tendon. Full thickness tears. Notice again, bony irregularity. Tendons, when they're insertionally torn, will tear and retract proximally. You could measure the length of the tear. Some will have abundant fluid replacing that volume loss. Others will have a kind of a complicated echo pattern to them. You can have granulation tissue or synovial thickening, but notice the bony irregularity that will always associate with an insertional tear. Here's where you see some flattening, where the rotator cuff has lost that convex bursal contour. So you have a tear that's torn off, retracted back, and that area of volume loss is taken up by deltoid and bursal tissue that has dropped down into that area of tear. Some tears are vertical in nature, where there's a frond of tendon tissue still attached to the greater tuberosity. And a maneuver that's really helpful in demonstrating these pinhole tears, where those two torn ends don't distract, is to place a patient in modified crass, place your hand against their elbow and have them apply passive movement against it, and that'll stress the proximal tendon and sometimes stress it enough that some fluid will fill that gap. So a linear line across tendon fibers may represent a tear. If it's a linear line going in the course of tendon fibers, it may just represent calcium going through those tendon fibers, in between the tendon fibers. Speaking of calcium, percutaneous calcium aspiration under ultrasound guidance is very productive in eliminating patient pain in a non-surgical approach, and frequently what you'll retrieve is this toothpastey type of material. And if you're interested in how that procedure is done, there's a very specific way to kind of lavage those that not only myself, but I know another person in the room has had great success with doing, and would strongly encourage ultrasound guidance for that non-surgical approach to calcific tendinopathy. Fluid in the subdeltoid bursa, as we talked about, has that appearance. Posterior glenohumeral injection with Sono-MBE. Whenever you see this box, you know that MBE is on and enhanced needle visualization is on. So here's the needle, brightly displayed here, posterior labrum. So here we're going to see a long axis view of the needle coming in deep to the posterior labrum, into the shoulder joint. From lateral, this is the top of the shoulder, this is lateral, so the needle's coming in plane under the transducer, tangential to the humeral head. Now I've heard of a number of ways of doing this, and some people come medially, perpendicular to the head. Our approach has always been to come tangential to the head so that we don't run the needle into bone, and just place it. That space is larger than you'd think. And then what you can use color Doppler to see the injectate going in right there. See that? See the needle right here. We're not using Sono-MBE here, so you're not seeing the needle very well, but if you look closely, you'll see with color flow how you can see the injectate going into the shoulder joint there deep to the labrum. Bursal injection, I don't have a video clip of, but you can see the needle very clearly placed into the subdeltoid bursa, just over the bursal side of the rotator cuff. Acromioclavicular joint, this is the patient's neck, so transducer placed on top. This is done either in plane or out of plane. I prefer the out of plane technique. With superficial structures, it works quite well. Notice here you'll see the tip of the needle come across the transducer plane and enter the image right there. We've got this center line so that you know where the center of the image is. Transducer, as you can see here, is lined up with a little arrow that you'll see on the transducers back here when you come out of plane. So you place your target structure in the center of the image, marked by this green line, and line your needle up with that arrow at the appropriate angle, and then you'll see that needle tip come right into the joint space there. Or it can be done in plane. And this one, the needle's already in, but you'll see the injectate going in there. There you go. So, thank you for your attention to all of this. Hopefully we've covered some of the history of shoulder ultrasound, where it came from, pitfalls, common abnormalities, and we'll proceed now with a demonstration of what constitutes a complete shoulder ultrasound study. Always start with the patient in neutral position, so I'm going to ask Kyle to just place his hand on his lap there. Transducer anteriorly on the shoulder, and go find the intertubercular groove. So you have the intertubercular groove, the biceps tendon on end. Notice how with beam angled off perpendicular, how the tendon becomes dark. Example of anisotropy. Simple cephalad tilt produces a brightly echoic biceps tendon. Working down distally and changing my depth, one click, we'll work down until we see the pectoralis tendon coming over the top and attaching to the humerus. And if you want to see the pectoralis tendon stretch back and forth across, you can internally and externally rotate the arm. Ultrasound's a very nice way to look at the pectoralis musculotendinous junction. Working back up in short axis, biceps tendon, and now at the top of the groove, you start seeing subscap with some anisotropy where the tendon fibers are coming in this direction, so obviously you lack beam perpendicularity. After looking at the biceps tendon in short axis, turn the transducer 90 degrees, and you will find the biceps tendon and long axis with its linear fibrillar pattern. And follow the biceps tendon down the arm until you get to the musculotendinous junction. Right in here, you start seeing biceps muscle belly. So just by doing that, we've established that the biceps tendon is not subluxed, it's not torn, and that there's no biceps tendon sheath fluid. Following interrogation of the biceps tendon, we're going to ask Kyle to externally rotate, and you see the subscapularis tendon come nicely out into view. And you can see with internal and external rotation dynamically how that muscle follows the motion of the tendon. Further medial, bony acoustic landmark of interest when you're doing ultrasound is the coracoid. And in this position, you can look at those structures past the coracoid and look and see if there's any element of snapping or bunching of that tissue as it passes the coracoid for subcoracoid impingement, the presence of. After having looked at the subscap and long axis, we're going to turn the transducer 90 degrees. I'm going to go find the coracoid. And remember, because I'm back long axis now, the subscap, okay? Back to long axis. So if I'm going to see this part, the proximal subscap, when I turn the transducer 90 degrees, I'm going to need, for 90-degree angle, I'm going to need to angle from medial to lateral. From medial to lateral. So I'm going to go find the coracoid, turn the transducer 90 degrees. So now I'm looking at the coracoid, and I'm going to hold my transducer there. I'm not going to slide it. I'm going to hold it, and I'm simply going to angle it laterally. And what you'll find is the muscle of the subscap, and further laterally, the tendon. Humeral head, articular cartilage, musculotendinous junction, muscle tendon of the subscap, working out distally. You see the now we're just in the tendinous portion of the subscap, still over the humeral head. I know that because we're seeing articular cartilage. Working out, advancing more distally. Now I'm over the footprint of the tuberosity, and you're starting to see those tendon bundles. See those zones of anisotropy in between the tendon bundles of the subscap. Now I know I've cleared the subscap when I get to the biceps tendon in long axis. Now here's another, just quickly. I've started doing this instead. I find the coracoid, angle laterally until I see proximal subscap, and I let the patient do the work. I'm just going to have him go from his position of external rotation to internal rotation. I'm not moving the transducer a bit, and that by nature interrogates the subscap from proximal to distal. See, there's biceps tendon that just now came in. Everybody see that? Both my hands are working here, so I can't. There's distal biceps tendon right there. Not distal biceps tendon, but biceps tendon just beyond the distal subscap. And if you externally rotate skin, see now I'm back into subscap. Further external rotation will come into the musculotendinous junction of the subscap. So I'm letting the patient do my work to see from proximal to distal through the subscapularis tendon now. Look at the supraspinatus tendon. I always start with their hand down by their side. This doesn't work with everybody, but it works with people with very little lateral body wall mass, like Kyle. You don't have too many Kyles as patients, I understand. So to look at the rotator interval, this is frequently a very nice position, and if the biceps tendon isn't sitting on top, you can rotate their arm back and forth and move that biceps tendon wherever you want it to be. I like to put it on top so that I can see the sling of tendons that anchor the biceps tendon into its interarticular portion between the subscap and the supraspinatus, and look for any defects here. Frequently you'll see a little bit of fluid in the biceps tendon sheath there. Don't mistake that for an area of tear. So after I've looked at the rotator interval closely, then I'll have him either bring his hand up to his side with the fingers down and the thumb forward, or preferably take his hand behind him. That will extend as much of the proximal rotator cuff out as can possibly be seen. There's just to show you, there's coracoacromial ligament right there. So now his biceps tendon is going to be rotated far more anteriorly and medial. Here's coracoid, right there. Biceps tendon. Anterior supraspinatus. I'm over the humeral head, so I'm over the proximal portion of the supraspinatus. Here's that oblique line separating, overriding infraspinatus and underriding supraspinatus. If I come down distally, now you're seeing those two flattened zones along the tuberosity. Here's infraspinatus fibers attaching, supraspinatus fibers at their enthesis. After I've looked from proximal, coracoid there, proximal, and I've scanned all the way out through the distal portion of the rotator cuff, now I'm going to turn the transducer 90 degrees. Again, I like to find coracoid and angle laterally to come into that bird's beak view that this is akin to a coronal MR. It's a long axis view of the supraspinatus, bony footprint of the greater tuberosity, humeral head, articular cartilage, subdeltoid bursa, and overlying deltoid muscle. Deltoid muscle coming up and attaching to the acromion. Proximal rotator cuff, distal rotator cuff. I always like to scan medially until I find the biceps tendon. Now I know I've seen the most anterior portion of the supraspinatus. Then it becomes just a matter of sliding and rolling the transducer around the shoulder. Better practice what I preach, keep my target in the center third of the image, right? Notice when I do that, did you notice the resolution improvement by placing that in the center third of the image? Notice how those fibers light up a lot better now? And working around posteriorly until we get into the infraspinatus, which you see there, and it's an attachment on the distal footprint of the greater tuberosity. Then give myself a little more depth and work posteriorly, and we're now into musculotendinous junction of the infraspinatus. So that's pretty much my examination of the rotator cuff, but as I mentioned, other structures are very important to look at too. The AC joint, transducer placed on top of the shoulder, as you would expect in somebody his age, very nice, smooth, bony surface. Impingement test, you can, for subacromial impingement, if you hold the transducer in long axis over the supraspinatus and have the patient abduct, you can see the rotator cuff slide back and forth under the acromion, and so you're looking again for thickening of bursal tissue or of the cuff itself as it slides back and forth under the acromion. Posterior aspect of the shoulder would be the last thing that we'd look at. They need a little more depth here. Have the patient bring his arm across his tummy. Humeral head, articular cartilage. So this is lateral, this is medial. A little more depth so that we can see the brightly echoic posterior labrum. So again, needle placement from a lateral approach would come this way and be placed right here. And then the spinal glenoid notch right here. Now bring your arm out, externally rotate. Let's see if he's got one of those veins. There, you see the vein distend right there? Now bring your arm back across your tummy and it flatten out. So make sure you do that in internal rotation. That's a shoulder study. Let's go scan.